In this video, we are going to look at liver function tests, what they are, and how to interpret them. Liver function tests are used to detect several biomarkers in the blood. The combination and trend of these results should be used to predict a patient's metabolic capacity. Generally, an abnormal result is one in which the LFT result is 2 times the upper limit of the normal range. There are 2 aminotransferase enzymes which are produced by liver cells. AST stands for aspartate aminotransferase, which is present in the liver and elsewhere in the body. It catalyzes the reversible transfer of an alpha amino group between aspartate and glutamate, so is an important enzyme for amino acid metabolism. ALT stands for alanine aminotransferase, which is predominantly present in the liver, so more specific to damage. ALT catalyzes 2 parts of the alanine cycle, where amino groups and carbons from muscles are transported to the liver. When these enzymes are out of reference range, this indicates that hepatocytes are damaged by inflammation or cell death, with the injury causing the enzymes to leak from hepatocytes into the blood. Blood levels are therefore elevated in acute liver injury, exposure to drugs or other substances toxic to the liver, obstruction of bile ducts, cirrhosis, and tumours. The ratio of AST to ALT can be used as a diagnostic aid but should not be relied upon exclusively. Alkaline phosphatases, ALPs, are a group of enzymes present throughout the body, predominantly in the liver with isoenzymes ALP1 and the bone as ALP2. There are also small amounts produced by cells lining the intestines, ALP3, placenta, and kidneys. ALP plays a role in the growth and development of bones and teeth. In LFTs, the total ALP is measured, with levels varying with age, gender, and blood type. High levels indicate cholestasis, where flow of the blood into the intestines is obstructed, for example, by gallstones. Gamma-glutamyltransferase, GGT, is an enzyme produced by hepatocytes and bile ducts. GGT functions in the body as a transport molecule and plays a significant role in helping the liver metabolize drugs and other toxins. It is released in all types of liver dysfunction and therefore can't be used to differentiate between different types of liver damage. Bilirubin is produced by the destruction of red blood cells. Hepatocytes conjugate bilirubin into a water-soluble form which is excreted in bile into the intestines. Bilirubin is the main pigment of this bile. Damaged hepatocytes are unable to perform this function, so levels of unconjugated bilirubin rise. When they reach over 50 micromoles, jaundice occurs. High bilirubin, ALP, and GGT indicate cholestasis, so movement of bile from the liver into the gallbladder is prohibited. Albumin is a serum carrier protein produced solely by the liver and therefore is a marker of synthetic function. It has a half-life of 20 days, so indicates chronic rather than acute liver disease, as it will take at least a week for the level to fall below that of the reference range as a result of liver damage or dysfunction. Low albumin levels can result in fluid leaking into the interstitial space and can clinically present as pitted edema in the legs where pressure leaves an impression, and ascites where fluid accumulates in the peritoneal cavity. The liver produces vitamin K-dependent clotting factors. A high prothrombin time and INR indicates decreased synthetic function, for example, liver cirrhosis, acute hepatitis, or impaired vitamin K absorption. This causes an increased risk of bleeding, for example, in the gut. These changes in prothrombin time are faster than the changes in albumin, so are more useful for hepatocellular damage in acute situations. We have covered all the biochemical markers tested for in LFTs, and I hope you now have a better understanding of what results can indicate.